So, it's a great pleasure to interview Professor Gerhard Schneider from the University of Munich.
Yeah, the Technical University of Munich.
Yeah, okay. I'm Professor Mike Wang from University of Leicester in England. So, I'd just like to begin by asking you about general anesthesia in terms of what is your definition of an adequate general anesthetic?
I think one of the key issues of an adequate anesthetic is what the patient is expecting from it. So the consciousness is basically, or the loss of consciousness, of conscious perception is basically the key issue, because that's what a patient would expect from a general anesthetic. But it goes beyond that, because there may be changes in the physiology which are also required to produce this status. So it's stability of the nervous system, of the autonomic nervous system, it's blockade of pain or of nociceptive stimuli, and it's the absence of conscious perception.
What do you make of the fact that some of our colleagues think that it's perfectly acceptable to aim for amnesia?
I would not agree with this point of view, not at all. In an extreme, this would bring us towards a point where we say that a certain group of patients does not require anesthesia. There are patients which have amnesia as part of their pathology.
Sure.
Thinking of Alzheimer's patients, I would not agree that these patients do not require anesthesia and that it's sufficient to go through surgery without anything with them.
Sure.
So what's valid for them should be valid for the average patient as well.
Yes. And of course we've also got the issue of neonates. It took a class action, didn't it, in the United States for neonatal surgeons there to agree to use
and
anesthesia.
to accept to use anesthesia for them.
And of course their justification was they supposed that there would be no memory in adulthood. But, yes, that's.
I think it's an weak argument. If you, on the other hand, have a patient who agrees that this is sufficient, you sure have to make sure that all the other components are maintained. So, for example, you want to perform regional anesthesia with an amnesic component. This would also be perfectly acceptable if the patient is okay with that.
Right.
But it's always a matter of expectations of the patient and of expectations what's supposed to happen.
Yeah. Okay.
I think most of our patients would give a very clear answer. If expecting anesthesia, we would tell them, you may be awake, but you won't remember.
Yeah.
And this is sort of the level that's the goal.
Sure. I'm sure you're aware that Jamie Slay's group and Jamie Slay's group have talked about connectedness or disconnectedness. J.D. Pandit is talking about dysanesthesia. And these appear to be states that aren't quite full consciousness, but they're somewhere between full consciousness and unconsciousness. And I think J.D. has gone so far as to argue that it's acceptable to target this state for a general anesthesia. What do you make of that?
As I mentioned, one of the key questions is what my patients are expecting. I would not think that I would find many patients to accept this state. And having said that, it may become an acceptable state in the future if we understand mechanisms behind it. It sounds very appealing in part because if you maintain your brain in a status that is also present during consciousness, it may potentially help to avoid some of the consequences of anesthesia that we see at the moment. But I do not see that we are any near to understanding what's happening in this stadium, and therefore it's not a clinically relevant status that I would want to reach, even if it may be some ultimate goal in the future. This is actually something we learned from our sleep research, that during deep sleep we have connectedness in the brain. So during dreaming, patients or all of us have a brain activity pattern that really resembles the awake status, but we do not get any information from the outside in that status. So if we could someday reach such a status, this may be way more physiological than what we do at the moment performing anesthesia, but as I mentioned, it's not where we are at the moment.
What do you make of patient movement, intraoperative patient movement? If you notice a limb move, what would you think and what would you do, assuming that there's no neuromuscular blockade involved?
It's an important indicator for me that there may be something going on with the patient in terms of awareness, whereas it's not a guarantee at all. We know that there is a lot of unintentional movement, that there are reflexes which are occurring at a lower level than the brain. So I would be careful watching them and trying to contact the patient in this status. So just asking,
you speak to them.
I speak to the patient. If he's able to move, he's obviously able to move hand and therefore signal that there is something going on. It won't be an isolated movement of the limb or the leg. So therefore, it allows me to get in contact.
You wouldn't be reaching for a muscle relaxant?
I would not, whereas I see in some of my colleagues that they do, and I can appreciate that they want to create an operating field which is ideal for the surgeon and ultimately for the patient to have safe surgery. But on the other hand, I have to make sure that the goal that I have with the patient is not at risk during such an action. So I want to maintain contact and make sure that the patient is asleep, and if this is the case, or is unconscious, and if this is the case, a muscle relaxant may be acceptable in this situation if the movement itself prevents the surgery to be performed safely.
Wouldn't you though think about deepening the anesthetic before you thought about the muscle relaxant?
I would think about it as long as I do not have a patient's response. I would not necessarily see it as a requirement. Now, the specific situation that we have at our department is that every single patient is monitored with an EEG. So I would also look at the brain activity pattern to decide whether it goes towards waking up or awareness, or whether it's just a movement which is more towards reflexes.
You touched on an interesting issue, for me anyway, which is about the dynamics and the politics of the operating room and the extent to which the behavior of the anaesthetist is kind of controlled by the surgeon. Probably not consciously, but because the anaesthetist feels in some way beholden to the surgeon in certain respects, and perhaps concerned that the surgeon's evaluation of their anaesthetist may be compromised. And for that reason, maybe many anaesthetists would be reticent about communicating with the patient or attempting communication, because their surgical colleagues might think, doesn't he know that the patient is unconscious? What's going on here?
Actually, I started this as a resident, talking to my patients. It was part of my research field, and of course, at the very beginning, I received some comments Now this is a guy who doesn't know how to anesthetize. He's talking with his patients. He doesn't know what he does. On the other hand, if you explain what's going on, you recognize that this behavior changes general behavior in the operating room and in the operating theater. So if you announce that there is a minimal chance that the patient is able to perceive something, this dramatically changes behavior of all persons present in the operating theater, and I think it's an important issue. It's an important way to go. I understand that it's a psychological requirement, or maybe a psychological requirement of distance for the surgeon to create to the patient during the procedure of surgery, because nobody would intentionally cut somebody with a knife. So there has to be some emotional distance that needs to be created, but it's not necessarily required that this has to translate into behavior in the operating theater.
That's really interesting, because it seems to me that what you're saying is that if even a resident, even a very junior anesthesiologist who's in training, actually expresses a view in the operating theatre, actually articulates that there is a chance that the patient could be perceiving things and you need to check that out, so you're giving a justification, and it's not that you are incompetent, that actually that causes a change in the sort of sociology, if I can use that word, of the operating room staff.
It does, it definitely does. That was my impression. Then, but it's often that the anesthesiologist or the residents in charge do not really have enough self-trust to point that out. And so it's maybe easier to just put in muscle relaxant, have the patient paralyzed. Nobody would realize that there was something going on if there was something, and that sort of part of it may be to maintain a professional impression on the team, but that's just basically it's the opposite, because you try to hide something, or you avoid a clinical monitor.
Okay, and that's a neat segue into me asking you about monitoring. You have published quite a lot on the issue of depth of anesthesia monitoring, and indeed you're going to be talking about, or you have talked about that issue at this conference. I wonder if you could just give us an outline, for the sake of the camera, of the lie of the land. What's the current situation? I mean, we know that there are processed EEG monitors such as BIS and Entropy. There are perhaps lots of pioneering and innovative new things on the horizon, perhaps about to come out, and also I would want to argue for the isolated forearm technique, which I know you have experience of yourself. So could you just give us some general comments about the whole area of monitoring?
I think there are the basic clinical tools and the clinical assessment, which everybody uses on a regular basis. They are...
Do you think they work?
Quite imperfect, but they give an impression. It strikes me that if you want to add information to this, there seems to be the perception that the information that you're adding needs to be perfect. So we're living with imperfect tools, and adding something which is also imperfect but may add information is actually hard to do. This is what surprises me a little bit. Maybe it's the impression that some of the devices gave that they may be perfect tools and everything is solved. It's not the case. But there's important information which is added. And this is both true for a clinical method as the isolated forearm technique and for EEG-based monitors. We saw them or started to see them, I think, 20 years ago in the first operating theaters. And there was a high expectation connected to the new innovation. And by now we know that this is just has not been fulfilled. But as compared to what we had before, I think we have done a great step forward, and we have started looking at the main target organ of anesthesia, which we basically had ignored for more than 100 years. So there is some benefit. We are not at the end of the road, though. The benefit is that we have started looking into brain activity. It has started a whole new field of research, and we start to understand what's going on during anesthesia in terms of consciousness and loss of perception and loss of consciousness. So I think it has advanced the field very much. The good thing is, I have the impression we are now at a point where we really start to look into basic EEG stuff and basic EEG interpretation on a greater level. There had always been experts who were able to read the EEG or read parts of the EEG, but with recent developments, I think it's become more open to the clinical anesthesiologist, and that really is one of the major advantages of getting those machines on the market, because everybody or many of us had started to look into details of the EEG, and it has been shown that it requires some basic training, and then you are pretty much able to do a basic interpretation of what's going on. Our brain and our eyes are so able to capture complex information that even if you can say the EEG has these features, you would realize it looks different than it looks at all with all your other patients. And this is an additional information that you get if you apply this method. So therefore I think it's very useful.
And of course the danger we have, certainly I can't comment on what's going on in Germany, but I do know that in the United Kingdom, as a result of the NAP5 activity survey, there's something like 40 to 50% of all hospitals in the United Kingdom and Southern Ireland and the Republic of Ireland actually have BIS monitors, possibly entropy, but a processed EEG monitor, but only about 15-14% of the anaesthetists are actually using them. And that's partly because they distrust the number, the single number. But I also think that it's possibly because they don't think that awareness is a big issue. And sadly, I think that NAP5 is currently being used as a valid indicator of incidence of ARGO, which I think is very regrettable. I'm sure you do too. And that's the problem. You have an anaesthetic community who already think that awareness is much less common than the 1 in 600 that Bryce interviewing tells us it is, and then they have NAP5, which is now apparently telling them that it's 1 in 19,000. So they're now thinking, oh, well, this is no longer significant and I don't have to worry about it. But what I think is really great about what you're saying is that in your practice, you've got the raw EEG signal in front of you, and you know well, at least you have the tools, the cognitive tools, to interpret that signal without a number. And really, somehow, we have to persuade your colleagues that everyone should be doing that.
I think it's an important recommendation if you use a number which is calculated by some algorithm that you really don't know, that you have to have a look at the raw signal. And it's been shown by Avidan and colleagues that you can train residents to read the EEG in such a way that they can reproduce the bispectral index number.
Sure.
So it's not hard to do.
Yeah.
It's even if you don't know what the reason behind it is, it's just a visual impression that you get from that. And I think it's even more important to have this in place, because it's not only, even if you do believe that awareness is not an issue, you should have a look at what you're doing to the brain.
Yeah.
And it's been stressed out tremendously that deep anesthesia or maximum effect of anesthetics on the brain may also not be ideal. Data are not entirely convincing yet, but we know that there are certain patterns of EEG which are physiologically just not appearing, and we try to avoid them. This is namely burst suppression, which is a suppressed EEG with high activity intermingled in between, which is can only be observed during certain pathologies and during very, very deep anesthesia or very high concentrations, inadequately high concentrations of anesthesia. So if you do not think that your patients may be aware, start using the EEG to avoid this pattern. And if you start using the EEG, you may once in a while run into a patient where you see that the EEG pattern turns different than in other cases, and not different in terms of too deep but too light or not sufficient effect. So this may help.
Sure. If you needed to have an anesthetic for surgery, what sort of monitoring would you ask your anaesthetist to be using, or what would you hope that they would be using?
To be honest, I had to go through some surgery, and I personally definitely prefer regional anesthesia without sedation. So if this is not possible and I need to go through general anesthesia, I would first of all select a colleague or choose a colleague who's able to integrate information from a lot of
different
devices
sources.
And different sources, who has some experience with the surgical procedure that I'm undergoing, because no monitor can tell you what's gonna happen in the next minutes of the surgical procedure. That's only the clinically experienced anesthesiologist, and that's part of the training of our residents, that they go through this surgical process intellectually to understand what's gonna happen. And then, yes, I would like to have an EEG.
Yeah. Okay, I think I'll
Curious, how many leads do you use in your routine use of EEGs?
We use a one channel only in routine. Yeah. So we do evoke potentials in specific cases. We do on an experimental basis a more channel EEG. But for clinical routine, we just use one of these devices on the market and put a one channel EEG on.
And in terms of burst suppression, so if you use one, then so do you think burst suppression, so you don't have two parts of the brain to compare?
It's a general phenomenon. If burst suppression happens, it happens all over the cortex.
Oh, it is?
It's not localized.
Okay. No, that's it. That was great.
Yeah, thank you very much indeed.
Thank you.
Yeah, that was great. You got the job.
Sounds good.